you so much for inviting me to present our findings on a study on responses to self-neglect and hoarding behavior among older people today. And I hope that you can all see my slides now. I think there might be a small delay with slides coming up, so I hope it will sync with my presentation. I'll try my best here. So yes, this is a study on responses to self-neglect and hoarding behavior among older people. Even though it's just me presenting today, this was obviously very much a team effort, and I'd like to say thank you to my colleagues. And I'd also like to say thank you to the School for Social Care Research for funding this project. And all the views that we are and opinions that we might be expressing in this presentation are those of the research team. And a big thank you out to our participants and the members of our advisory group, who, as you will sort of find out, have been people with lived experience as well, which was very kind, because as you might know, if you work around this field, there's a lot of stigma around this topic, and that was often very much a part of the discussions when we met with our advisors. So what did we try to do? We explored safeguarding and social care responses, and obviously also responses from other agencies who are involved in safeguarding or providing support to service users around our cases with self-neglect and hoarding behavior. And we just wanted to know what works in practice. So what are good approaches, but also obviously what could be improved and picked up in our sites, but also nationally. Short word on why we were doing this. As some of you might be aware, self-neglect became a potential safeguarding concern with the introduction of the guidance to the Care Act in 2014. So this was sort of, there's been a bit of an evolution around the policy around that. And if someone is really interested, I would invite them to read Stephen Martineau's report on self-neglect. And I will come to that because it's one of our publications. Just definitions, self-neglect, there is no real established sort of international research or even practice definition. It's typically understood to encompass person's lack of self-care. So this could be around hygiene. This could also be around not taking medications, but it also encompasses ideas of not looking after surroundings. And in that case, and as it is also mentioned in the guidance, hoarding behavior. We are now sort of looking at, well, we have said we're looking at hoarding behavior because this could be broader than just the two established definitions around hoarding disorder. Nevertheless, I think it's quite important to maybe make you aware of them, because hoarding behavior was part of obsessive compulsive or related disorders until about 2013, when the American Psychiatric Association came out with hoarding disorder as a independent diagnostic entity, and the World Health Organization followed in 2018, or as it was ratified in 2021. And hoarding disorder is sort of understood as accumulating possessions, items, to such a point that living conditions or spaces just become so cluttered that the safety of a person or the use of those spaces could lead to risk of harm, either for the person themselves, but also to others. And obviously this goes hand in hand with the inability of letting items go. But as I say, this is now recognized, at least in clinical fields, as a mental health condition. And in those terms should also be maybe looked at it if it comes to safeguarding concerns. So what did we do? There were three parts to our study. Initially, we looked at the literature and then also looked at policy documents that were published by safeguarding boards or by local authorities, and sometimes even by other agencies in those areas. We then undertook interviews, and those was followed by a thematic analysis. And our study also had an economic analysis. I will come to that in a second. So who did we interview? We started in 31 safeguarding adults board areas with interviews of their leads and senior managers. The senior managers were often people who were directly involved with cases of self-neglect and hoarding behavior. So that, they thought it was really important to, let us know about what happened in their area. We then moved on to 6 case study sites, and here we interviewed 33 senior managers. and 60 frontline staff, and they were from organizations and agencies that were part of the safeguarding boards. So those were obviously the local authority, adult social care services, this clinic, in those days it was still clinical commissioning groups, mental health trusts, we invited GPs, the fire service, the police, local authority, environmental health and housing, also housing associations, and the third and voluntary sector, and also professional declutterers. So in that case, these were often services that would go into a place, do certain things, and actually we are now doing a follow-up study on decluttering services, just to see how the services that they provide are actually differing. We also interviewed 8 older people with lived experience and 9 carers or relatives of older people with self-neglect or experiences of hoarding behavior. So some words on the economic analysis, and I'm not the expert on this. This is my colleague Michela Tinelli from the LSE. And she's very happy to let you know what she's doing, and maybe this is another presentation at another time. She basically developed a situation where we compared 2 different scenarios, and those were based on 3, as we sort of decide, typical cases of self-neglect and hoarding behaviors, where a person had come to harm. In the case of, in our case, the 3 people died. And we looked at the last 2 years and the service provision and the support that people received in those two last years of their life. And we defined this as the sort of unmet needs scenario, and tried then to work out, after obviously the experiences and findings and interviews and conversations with service provision, what a met needs scenario could look like. So where the person maybe not comes to harm, and what would good support could look like. And sort of compared that. And I will obviously show you some findings later on. We looked at the cost units, and those were based on the literature, but as I said, sort of conversations with experts in the field. And those were also members from the advisory group who have been actually really helpful in sort of discussing these cases and what should be done. And to our understanding, this was actually, we think, the first attempt at looking at the economics in this field. So what did we find? Well, if it comes to definitions, perceptions of self-neglect and hoarding behavior, and as I said, you know, it could be seen and should be seen as a mental health condition, and as a safeguarding concern. And we found that there was good understanding of this, but obviously in this case we interviewed people who were leading on this. And, you know, we're often involved in working with people with self-neglect and hoarding behavior. But when we sort of asked, you know, what do you think are the causes and the sort of consequences out of this, frontline workers who worked in the field very much were quite aware of findings in the literature, and said, you know, it could be caused by depression, anxiety, trauma, loneliness, and sort of, or be triggered by bereavement. And they felt that this was often also the case with hoarding behavior. And we say and or because obviously you can be a person who is self-neglecting and not showing any hoarding behavior, but you could also be a person who, you know, clutters their home, but obviously is very much looking after themselves. Some participants, as I said, were very much aware that there is no the sort of discrete diagnosis as defined either in the US or now by the World Health Organization. But I guess when we did the interviews, that was at a time where the World Health Organization definition was only just ratified, so people might not have been aware of that immediately. People were aware that it is classified as a safeguarding concern. Again, maybe not too surprising because, as I said, they worked in this field. Which maybe led to the sort of last finding around perceptions and definitions. Professionals and people with lived experience felt that some other practitioners who they were working with or who were supposed to support them still considered self-neglect and hoarding behavior as a choice or as a sort of lifestyle choice. And they thought that was quite problematic. Assessments, well, people often only came to the attention of statutory services when there was already considerable risk to harm to themselves or to others, which is obviously quite difficult if it comes to preventing situations. It was thought that a safeguarding inquiry was led by local authorities, adult social care services, and then the involvement of other agencies and organizations that were on the safeguarding boards or that should be involved in multi-agency working, I'll come to that in a second, actually really differed. And that also applied to, how much the individual themselves were involved in decision-making processes or in obviously the assessment process. There was a general agreement that if a person was not meeting thresholds for further safeguarding proceedings or something around that they should be definitely referred to adult social care services for then further assessment of other needs and how they could be supported. That could also be obviously signposting to other organizations. Mental capacity, very important point. There was an expectation that social workers, nurses, or also occupational therapists should undertake mental capacity assessments. And it was felt that in all cases, a mental capacity assessment should be undertaken and this should not be ignored. Most other practitioners would really say, we're not really trained to do this. This should be done by someone with the right expertise and also right experience of being quite careful how to undertake these assessments, even if that meant that another person needed to be involved in this case. But this was a general agreement, and actually also an agreement that came from people with lived experience. We found that if a person was assessed to have decision-making capacity, there was potentially an increase in the sort of the thresholds of further safeguarding inquiries. It was rather than referral to social care provision. If a person was found lacking specific decision-making capacity, then the interventions could be done more from a safeguarding perspective, bringing in also the side of the law a little bit more. Obviously, best interest decisions needed to be taken into account. But we also found that this sort of empowering ethos that is part of the Mental Care Act was not often observed or was not sort of on, immediately on people's mind. Doesn't mean that it doesn't happen, but it was just something that was not so much discussed in our interviews. Support that is provided and sort of the challenges around it. There was a general agreement that multi-agency responses and working would help people with self-neglect and hoarding behavior, that long-term engagement and building trust was very much important, rather than sort of quick interventions, cleaning, blitz clearing. People might have heard about that sort of, that often happens on TV. And often people felt that this is exactly the opposite of what should happening. This being rather, causing more trauma and all engagement that's sort of, building trust would actually be rather, destroyed by such actions. Although professionals also talked as a sort of a balancing act in, providing a support that decreases the risk of harm. It was often felt that there was sort of not enough knowledge what other agencies could be offering. So not knowing that the fire service might be running a peer support group, or that voluntary organizations could be involved in these cases and then actually quite willing to provide support. There was also widespread criticism that there's a lack of access to NHS mental health support, and this was the case actually in all of our sites. The length of support provided varied by the level of severity and risk assessed, but also by the engagement of an individual, and obviously by resources that were available to people providing support. And there was sort of, a revolving door problem happening. So if it comes to multi-agency working, there was an expectation that local authorities, adult social care services would lead. But there was also potential for institutional jealousy where other teams would like to take the lead. But that was then contrasted by saying, well, actually other teams are responsible and this is not our responsibility. So passing the buck, basically. There was, even though in specific sites where multi-agency working was supposedly happening, quite often a sort of a mixed picture of shared understandings of definitions and thresholds. And that was obviously often around referrals and how people should be supported afterwards. better collaboration on the level of senior managers, and more potential for silo working and thinking on the frontline level, often due to high caseloads and lack of resources. And as I said, the third and voluntary sector often said, we don't really get feedback if we refer someone, and we have a lot to offer, and we would really love to be fully involved, maybe in a sort of official multi-agency working. There's a potential to really increase that work. Information sharing, where we found that all the sites that were involved in our study had policies and protocols in place, and whether that worked in practice was a bit of a different question. There were often questions around from frontline workers around the sort of data sharing if a service user would not give consent for sharing, sort of around GDPR and questions around that. Training, absolutely mixed picture, and the main criticism was around that all training involved, talking about causes and consequences of self-neglect, but not, and obviously again, we talked to people directly working with these cases, they were looking for sort of hands-on tips and tricks, how to best support a person directly, but also a clear desire to have supervision, maybe with experts in the field, so not just their line managers, but maybe with someone who had more understanding around this. And this could be either within the local authorities, but we also heard other people who said, this could be something regionally organized or nationally organized, as we're all on sort of, online meetings and more used to that. And I come to the economic analysis. So as I said, we were sort of, comparing, Kayla was comparing unmet need scenarios with a met scenario. And this is definitely only based on 3 cases, so not generalizable in that instance, especially if it comes to numbers. And obviously also this, you can see the sort of the spending that was done, or the expenditure that was done in the 3 cases, differed quite widely, between 80,000 in one case and over 62,000 in another case. The expenditure was mostly around housing services, but also money was spent on eviction and court action, and actually quite severe money was spent on that. And there were few resources spent on mental health services or around drug and alcohol support, which could be something that should be increased. So when we then looked at the sort of met need scenario, the expenditure would increase in every case, and it would come still around housing services, house maintenance, but we would also increase local authorities' care budgets and spend money on voluntary services. And that could be, as I said, sort of peer support. It could be working with a therapist, it could be working with counselors, but it could also be, around drug and alcohol support. So a bit of a sort of one example here. This is Mr. A. And here we sort of try to show, the increase in money spent on adult social care and around the volunteer sector and mental health, who is now coming in, who weren't a part of it before, but obviously a greater reductions on the fire service expenditure and around criminal justice, and this was around a court action to evict the person. So what are our recommendations, or basically the recommendations of our participants? There was a great ask for establishment of specialist multi-agency teams, so professionals that would be working quite specifically on cases around self-neglect and hoarding behavior, and they should be coming from social care, social work, mental health, housing, the fire and rescue services, environmental health and community services, if they are available in their local area, and also for them to be equipped with the right resources to allow engagement with individuals on a sort of long-term basis, knowing that working with these people, that the situation, conditions of living situations would not improve within 6 weeks reablement, but can be something that can take years and might not actually ever really come to something you know, where the, if you are aware of the clutter, the pictures, some people might have seen that sort of goes from 1 to 9. It will probably never come to a situation where it's 1 to 3. But obviously the risk of harm can be decreased. So this is all around follow-up and monitoring of people. If there's not the resources to have a specialist team, then many people said that multi-agency working just needs to improve the communication between different teams, different agencies that are on safeguarding boards, just the communication, sharing information be tightened and have maybe complex team meetings, complex case team meetings, and that to be really improved. If external providers, and this could be decluttering services, but could also be charities. In some areas, we found that HUK are actually quite involved. If they are commissioned, then they should follow a therapeutic approach, you know, bring in counseling, or also be open to bringing therapeutic approaches for mental health services if available. And it would be great if community mental health services would be available to people. So this was something that was often asked for. Assessment, as I've mentioned, you know, should be done with great sensitivity to not threaten the individual and discourage further engagement, and more awareness around maybe practitioners and professionals who are not sort of directly working, but where they come across it. So to have this awareness that it is maybe not a choice, but it is a great concern, and then for them to make the right referrals, and just more training around that. As I said, with people directly working in this field, more specialist training or support, so that they would really know, you know, how to maybe in the long term really to improve outcomes and get the right, you know, situation involving the individual. Preventive approach is really difficult, just because people only come to the attention of agencies, you know, when it, I don't want to say when it's too late, but definitely when there's a considerable risk of harm. But it could be something to look into in terms of, you know, inspections in houses, and also then equip, again, other people to be aware of making the right referrals. And we looked at the economic evidence, and obviously an investment in social care, in mental health support, and the voluntary sector could definitely reduce the risk of harm in our view, in the view of our participants. So we've published, and a few lit reviews are out there, and 2 papers, and they're all free access. And that was it. Thank you very much for listening, and please pen down my name if you're more interested in our findings or want to have some more discussions. And I stop.
Thank you, Nicole. That's great. Great. So do we have any questions? I should have looked at the chat box to see if there are any questions aside. If there are any questions, so I was interested in what you were talking about. I mean, essentially, you're sort of suggesting, I think you can correct me if I'm wrong, and I apologize if there's any noise in the background because somebody's just walking in the house at the moment. But there didn't seem like there was really any leadership necessarily across the system with respect to that area. Is that right? Because you were suggesting that people thought that the local authority should be taking the lead, but it wasn't quite clear whether the local authority thought that they should be taking the lead, and whether even they had then the power to be able to get all the various organizations to act together and work together around this point. So I don't know if you just wanted to maybe expand on that a little bit more.
Sure. I think the one thing around this is really is, you know, what do I do in a case where I know that I can't improve the situation immediately? You know, this will be a long-term investment, and I don't mean that necessarily just with money, but obviously that is also the case. And I think when we talked to especially social workers, social care managers in local authorities, they felt that they were not equipped with this situation. They thought, you know, who do I go to who will then enable me to do that? So I think this is the way to, you know, where passing the buck maybe came in. I don't want to say that you know, they didn't take that seriously, and it was sometimes really frustrating to sort of listen to the stories in individual cases when they talked about it, even though we presented them initially with a sort of made up situation for them to react to. but obviously they had their experiences, and it really felt like the sort of almost powerless knowing where to go to. And I guess that is where the sort of lack of leadership maybe comes in. I think it is improving, but I think we were sort of, where people became aware, okay, this is something we need to look into more. There are more referrals have been made to local authorities, and they realized, oh, we don't really have working processes in place, and we're hoping this is really improving, not just because of our work, but just because of practice. And so I think that the sort of tightening around working together around specific cases was something that was picked up, having more complex case meetings, or bringing in a process that people could follow. But I guess when we looked at, what are the thresholds, what would you do? Then people often became stuck and sort of, said we're not entirely sure, because there's a lack of resources, or, we think we are not mental health support with the right expertise. And they looked at, then have more help. And I guess that is where this idea of a specialist service comes in, to say, it would be great to have, either a team or at least a sort of, self-neglect hoarding behavior champion.
I mean, what do you think about sort of the role of ICSs potentially then in this space? I mean, given that, mental health seems to be one of the areas where there's a kind of absence, and I mean, do you think they then potentially have a role in beginning to take some of the kind of leadership across the system, really, with respect to this area?
Well, we found it difficult to talk to them, so I guess that's a finding in itself. But I'm not going in how I interpret that. We invited them, we approached them. I know that in the sites, the people who sort of were or gatekeepers, and invited them again and again, and we tried to get them in. But I think this is also a sign probably of how overworked they are. We know from talking to psychiatrists in the field that there are sort of 3 or 4 national NHS providers. But I guess this is where charities like Hoarding UK, Hoarding UK come in, and could be really helpful and providing a sort of more an idea of how to process and work directly then with local authorities. And as I said, it's interesting how many in how many local authorities or safeguarding board areas the fire service actually plays a huge role in that. Because they are quite, they seem to be seen as the nice ones. So their uniform is seen as the positive uniform, so they're let in. And they seem to have a real, they don't see their role as, putting out fires. They see their role as preventing them. And they take that very serious. And that we have heard about quite a few services, organizing peer support groups, bringing in counselors, so that there is a therapeutic approach around that. How much the NHS will be able to do, I guess, in mental health, I guess depends on how much the sort of discrete diagnosis becomes a living thing and becomes practice. But I can only say we found out, we heard that there was a lack of access to it or involvement in multi-agency working, unfortunately.
Okay. Does anyone else have any questions for Nicole?
Hi, I have a question. Sorry, I couldn't put my hand up momentarily. It's Victoria. Hi, Nicole.
Hi.
I wondered, when you chose your case study sites, were there sites where people were using free conversations, innovations, and strengths-based working, and sites where they hadn't adopted that approach yet? Because I know I've been a safeguarding manager in the past for quite a long time, and I've worked in sites that haven't. And one of the benefits of implementation was that working under that kind of model was meant to help more with things like this. So I wondered whether that was something either that you encountered or analysed.
So yes, obviously we interviewed safeguarding leads in 31 sites, and then looked at different approaches taken towards self-neglect. So we heard from some sites that they said, we don't have anything really established around this. So you know, obviously we with that said, thank you very much, but you're probably not really to be a good site for us to look into what works in practice. That was part of it, absolutely. But there were lots of different ideas of what we were interested in. We were very, you know, having the economic analysis as part of our research proposal. We were looking at sites who said, yes, we can provide you with some data at least, although it turned out to be quite difficult for them to find them for us. So that was another aspect with regard to choosing our 6 sites. But yeah, definitely, you know, someone saying, you know, this sort of works for us, and different approaches within that was something that we very much looked at.
Thank you. And then just one more question, if that's okay. I wondered whether safeguarding adults managers understood or talked about very much the difference between a duty to coordinate and bring about a safeguarding and the expectation that they would do it themselves. Kind of relates to the earlier question about, you know, who took ownership or who took leadership, because there's a duty to coordinate, not a duty to actually do the intervention.
Do something, yeah. Depended on the site as well. I think there was a difference. I think we came across safeguarding leads who were very much, you know, looking at more on the sort of strategic level, wouldn't go into more details, saying, okay, yes, this is important, we're aware of it, and we're making changes of it. Whilst we became others who were more hands-on and sort of really, you know, work very closely with adult social care, but also with housing and with housing associations. So again, it depended on the site we're in. I think we were more interested in choosing sites where that was the case, just to have this sort of you know, variation. But also to have that understanding that, you know, we would get access to other agencies being involved, so, which was often, as we understood at the time, you know, something that the safeguarding board would be liaising on, or where they then put us in touch immediately with someone from adult social care and said, you know, they are actually leading on this. So we had a mixture.
Thank you.
Okay, great. Well, we're at 5 past, so I think we will leave that there, and I think thank Nicole for a wonderful presentation.